Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thank you so much for tuning into the latest edition of the Checkup. The COVID 19 pandemic, as we all know, has heightened longstanding problems the industry has been facing over equity of care issues. There are mountains and mountains of studies that I think we've all probably seen that show evidence that populations of color have disproportionately worse outcomes than white populations in terms of health outcomes. I'm really pleased today to be joined by Dr. Anna McKee. She is Executive Vice President, Chief Medical Officer, and Chief Diversity, Equity, and Inclusion Officer at the Joint Commission. We're going to talk about ways that the industry can and should be addressing health equity. Anna, thanks so much for being with us today.
Matt, thanks for having me.
So I want to start before we jump into some of the long-standing problems that we've been facing, that you've obviously been dealing with and seeing at the Joint Commission. Maybe you could just highlight or talk about what you think the past 18 months has taught us in terms of equity of care. There's obviously been a lot of talk about populations of color and how they've been disproportionately impacted by COVID, but is there a broader lens that you're viewing this through?
Matt, the last 18 months has taught us what we should have known for over 50 years. Disparities in healthcare is one of the most researched, talked about topic in academics and in research. Over the past 50 years, there's been more PhDs earned on this topic, yet the progress that has been made is pathetic. Perhaps the 18 months has put a focus on our attention, but still the response is slow.
Why do you think that is? As you say, it's been years and years we've been talking about it. So why do you think the response has been so lethargic?
I think on behalf of healthcare leaders, it demonstrates the lack of social responsibility, a focus on finances and other areas, rather than look at their communities that they serve and look for opportunities to address it. I think the attention has gone elsewhere from healthcare leaders.
So what are you seeing in terms of progress? Are there areas where you think, as an industry, we could shine a spotlight on and say, hey, this is really working?
Well, in reality, there have been some organizations who have been working on this topic all along. And what we're seeing now, if you go to any medicine conference, healthcare conference, this topic is on the agenda. So it's being discussed. If you also look at most of the healthcare associations, professional or trade organizations, they've all made statements. I want to give a shout out to the AMA, who came out with a very strong statement and then followed it with an acknowledgement of the history of AMA contributing to the injustice that results in disparities and other issues.
And so when you think about the progress, the AMA obviously won. I think AHA and some others have talked about it. Are there practical things that you're seeing boots on the ground that are working for organizations that maybe the Joint Commission or others could talk about more and get more into the field?
Yes, exactly. And that's the reason why we put out in a competition, a national competition, the Bernard Tyson Award for Excellence in the Pursuit of Equity. And that's going to allow us to highlight and feature leading practices, because there are organizations that are doing amazing things. So we do want to educate. We also want to talk to healthcare leaders that this is a safety issue. It's not a standalone problem. It's not okay if a woman of color goes to deliver a baby and she has twice the rate of an injury during that delivery. That's not okay. That's a safety concern. And we want organizations to turn to their quality improvement infrastructure to address these problems, not to build something completely new. They have the expertise. They need to look at the data, understand the root causes, and move forward.
Can you expand on that a little? Because I think we talk about equity of care in sort of a population health, a community health approach, and not so much in the quality and safety professional arena. So how are you at the Joint Commission thinking about it from a quality safety perspective?
Well, Actually, we're in the process of evaluating and speaking to experts about the potential of new standards that will ask organizations to assess the disparity issue, identify an opportunity, and then address it without being prescriptive on how it's going to be addressed. But that's the first step, is to identify a real opportunity and don't assume that you understand why that disparate outcome occurs. You really need to work with the community and people of those underrepresented groups to understand what are the true issues that keep an individual either from accessing care, following up through care, or staying within the healthcare arena.
And are there specific conditions or medical areas that you would start to look at? Or do you try to do this across the board of your universe of patients?
Well, we're encouraging organizations to identify that opportunity. And they really should not be difficult to identify. Whether it's vaccination rates during the COVID, we know that maternal infant morbidity and mortality is a huge opportunity there. So the opportunities shouldn't be difficult to find, but we want the organizations to own them. And they can only own them if they identify them and commit to improving.
And so part of that is data collection. We've been talking about and doing data collection for a number of years, and it's not been great. So what are you seeing on that front? Where do hospitals and health systems need to improve, and maybe even working with payers, I'd imagine, improve their data collection process?
Exactly. So the data collection process has been really challenging for many organizations. You have to train your staff to collect the data in an appropriate manner. Without that training and quality improvement approach towards the collection of data, what you start to collect is numbers that may not necessarily be real. So the first step is the education and training of all those who are going to collect the data. And then it's the analysis of the data, which organizations have more experience with, but they lack an expertise in the collection process.
Got it. And I want to come back a little bit. You had reference of the Joint Commission's working on maybe a new set of standards. Are there things that you think the federal government can and should be doing, from using their arm as a Medicare and Medicaid payer to force more work on equity of care?
Absolutely. I think the CMS in particular could help organizations on the accountability side of improvement, require metrics and outcomes, and also use the reward system. Compensate organizations that are really doing excellent work in this area, and work with organizations using their regulatory impact on organizations who are not.
Got it. I want to pivot a little bit, Anna, to the cultural aspect of this. Obviously, so much of this starts at a leadership level. Where do you think organizations need to start? And I imagine it may even start even younger than the CEO suite, as people are moving up the ranks. How do you ingrain in a culture this attention to equity of care issues? Where does that start?
I'm a big believer that it always starts with the governing body. And the governing body is instrumental in this effort. It may require resources, it does require leadership, and it requires accountability, which the board is ultimately accountable. The board has to view this again like any other patient safety concern. It's a central line infection, or it's a bad outcome because it was a Black woman. It's the same kind of safety concern.
Are you seeing boards start to think about this, or are you hearing conversations around that?
The conversations I'm hearing are not at this time coming from the board, but more from organization leaders, individuals that have been working in this space for a while are now getting a platform to be heard and educate others, which is really important. There's a difference between education and awareness, right? Education is the knowledge, you have the facts, and you have the language and all of that. To me, awareness is the application of that education. And that's where we need to be. We need to move from talking about the data, talking about the numbers, to applying solutions and being attentive to these issues. And also looking within our organizations and looking for those structural things that we don't see every day that actually are either dismissive to a community or are an impediment. And we
What's it?
all, Mhm.
Sorry, what's an example of something like that?
You know, it's very interesting. I was training in a segregated organization up here in the Northeast.
Hmm.
And the white patients were in one wing, the new wing, and patients of color in another. That was a sign of disrespect to a lot of the patients who came in. They did not like to come into the hospital because they felt they were going to be given a second status. And they were. So we have remnants of all of that still around us. And all of us who were educated in that system, those kinds of thinking are still hardwired in our minds. We bring that to work.
Yeah, I imagine so. And so, if we think about that education piece, what would you like to see at the medical college level of starting to build some of this into that curriculum? Because it starts there with those doctors in training.
Yes, and I'm glad to say that I've had discussions with the leadership team at the American Association of Medical Colleges. They are attentive to this matter and are looking for ways to begin to include this into the quality and patient safety training that they're doing. And so there are signs of energy beginning to occur in the healthcare leadership community and in associations across the nation.
Great. And lastly, Anna, in the last minute or so we have left, um, as you know, in this country, we have a pretty short attention span to things. And so obviously we've been talking about COVID, the murder of George Floyd have brought equity of care issues to light. As we get past, at some point, once we get past the pandemic, attention's going to turn in some way back to restoring finances for the health systems that have struggled during this process. So what's your concern about losing any momentum that this conversation has had over the past 18 months as attention shifts back to, some of the routine ways of doing business?
I'm so glad you asked that question because in a couple of months or maybe in a year, this will not be the topic of the day. I think, however, we as leaders have to now transition from the ethical and the moral responsibility of doing the right thing and looking at it as a quality concern to now having discussions about what's the financial impact to an organization who is not taking care of all of its patients equally. If you're doing risk contracting, and 40% of the Blue Cross Blue Shield business is risk contracts, you are losing a financial opportunity. Because when you do a crash dialysis on a patient, you spend a lot more than when you do elective dialysis on a patient. All of these disparities organizations lose when they're in an accountable care model, a bundled care model, or risk contracting. So we have to now state the case for finance. Unfortunately, just talking about the right thing is not going to do it. But we have to start to focus organizations on the financial opportunities and the financial impact of providing disparate care.
Right. Well, great. And Anna, we certainly would love to follow up with you on this topic, as we go forward. But we appreciate all your insights and all the work you're doing on this stuff. So thank you so much for taking some time.
Thanks, Matt. It's great talking to you.
Thanks. And I'm Matthew Weinstock with Modern Healthcare. Be sure to come back for another edition of The Checkup.